Today we are going to study to the breast in male and in female. First of all, we have to define what is the breast. The breast is the mammary gland, is the milk secreting gland that occupies the pectoral region. It is the milk secreting gland which occupies the pectoral region. If this is the chest and this is the upper limb, and if we have the sternum here, the breast is the mass that occupies this region. The breast is mainly formed of fat, superficial fascia, the fatty layer of superficial fascia, which is covered by skin. And its shape, it looks like a hemisphere. As I told you, it occupies the pectoral region. And all of it is present in the superficial fascia and is covered by skin, except a part that comes from its upper lateral part. This part goes into the axilla. This part goes into the axilla and is called the axillary tail. So, this that goes into the axilla, it passes to the axilla by going to the by passing through the base of the axilla. So again, it is a mass of superficial fascia occupying the pectoral region, and it has a part that pierces the base of the axilla. This is the deep part and it's called the axillary tail. And it is hemispherical in shape. The axillary tail comes this way to go into the axilla. What is present here is the base of the breast. And over this base there is a mass of fat and the skin. The limits of the base of the breast is fixed in both males and females. The upper limit is the rib number 2, and the lower limit will be the rib number 6. Medially, the breast is limited by the lateral border of the sternum. And laterally, it goes into the axilla till the mid-axillary line. So, when we ask what are the limits of the base of the axilla, we say it has an upper limit, which is the second rib. It has a lower limit, which is the sixth rib. And medially, it is limited by the lateral sternal border, and laterally, it goes into the axilla till the mid-axillary line. And all of the breast is in superficial fascia, is a superficial structure, superficial fat covered by skin, except the tail of the axilla that goes, the tail of the breast that goes into the axilla from the base of the axilla and pass into the inside of the axilla. This is called the axillary tail. This is the deep part of the breast. The skin of the axilla is very smooth and having in its middle the nipple. And the nipple is the protruded part of the breast where the milk ducts, about 15 to 20 milk ducts open. This nipple is surrounded by a colored skin, which is called the areola. So this is the nipple, and this will be the areola. So again, the breast is a mass of fat, superficial to the deep fascia, and this mass of fat is covered by skin. In the middle of this skin, there is a nipple where the milk ducts open, and the nipple is surrounded by the areola, and the areola is the colored skin over the nipple. The breast base is bounded anteriorly, is bounded above by the rib number 2, below by the rib number 6, medially by the sternal border, and laterally by the mid-axillary line. To have an idea about the structure of the breast, we'll take a section, sagittal section in the breast. Therefore, this section will go till it reaches the muscles. And of course, the main muscle of the pectoral region is the pectoralis major. Below the pectoralis major, there is the external oblique muscle. And these muscles are covered by deep fascia. Of course, if we go laterally, instead of pectoralis major and external oblique, we'll find the serratus anterior muscle inside the axilla. And this will be the skin of the axilla. And of course, here there will be the nipple, which is surrounded by the areola. And all this substance is fat. So this is the deep fascia. The breast, all of the breast is superficial to the deep fascia and is mainly formed of fat. Between the breast and the deep fascia, there are loose areolar tissue. There is loose areolar tissue that forms a space which is called retromammary space. This space makes the breast easily movable on the deep fascia. It helps easy movement. And if there is cancer in the breast, the cancer will invade this space and go to the muscle and fixes the breast to the muscles. Therefore, if there is a breast mass, and if this breast is immovable on the pectoralis major, this means that there is cancer that has invaded the space and has gone into the pectoralis major, fixing it to pectoralis major. So, if we ask what are the structures deep to the breast or deep to the breast base, this is the base, the retromammary space can be considered as the base of the breast or the mammary gland. And the nipple can be considered as the apex of the breast. The base of the breast is fixed in both male and female and extends from rib 2 to rib 6. Now, when we go more in the details of the breast, we'll find that from the deep fascia there are strands of fibrous tissue of deep fascia that go to the skin of the breast. About from 15 to 20 strands. This will fix the skin to the deep fascia over pectoralis major, external oblique, and laterally over the serratus anterior. These deep fascia, strands of fibrous tissues or strands of deep fascia, are called the suspensory ligaments of the breast. They make the breast protruding forward. And in old age, these ligaments become weak, and therefore the breast comes down. Therefore, we say that the breast of the adult female is protuberant, is directed forward. And in all the females, we call the breast pendulous, that is directed down. So, regarding the structure, we'll find that the breast is divided into lobes, separated from each other by ligaments. These ligaments are suspensory ligaments, which come from the deep fascia over the muscles, deep to the breast or deep to the base of the breast. The deep fascia gives these ligaments, called suspensory ligaments, fixing the skin to the muscles. This is the structure of the breast. In both male and female, they are the same, except that the amount of fat and the glandular tissue are rudimentary in males. But in females, we'll add to the lobes the glandular tissue, which will be in the form of alveoli that secretes the milk. These alveoli will secrete the milk into ducts, and the ducts will join together to form a lactiferous duct. The lactiferous duct will be directed to the nipple. And before opening into the nipple, it will have a dilatation. This dilatation is called the lactiferous sinus. And the milk comes from the alveoli to the ducts, then to the lactiferous duct, to the sinus, where it is preserved here. This sinus acts as a reservoir for milk for the baby. When he needs milk, he will find the milk ready here in the sinuses. We have about 15 to 20 lobes. Therefore, we'll have about from 15 to 20 lactiferous ducts. Now, if we go to the breast as a whole, if this is the nipple, and we said that the nipple is surrounded by the areola, from the lobes of the breast of adult female, we have lactiferous ducts radiating to the nipple and open into the nipple. And as I told you, at the end of each duct there will be a sinus which acts as a reservoir for milk. It preserves the milk for the baby. When he needs, you'll find it. If there is an abscess in the breast, we have to take an incision which is radial, radiating out from the nipple to the outside. Because if we take the incision vertical, it will cut many ducts. And if you take it horizontally, also it will cut many ducts. Therefore, we have to bear in mind that the lactiferous ducts are about 20 ducts, from 15 to 20. And these ducts are very well developed in female and non-developed and rudimentary in male. This is the only exception. The base of the breast of male and the female is the same, have the same limits. The structure of the breast in both male and female is formed of fibrofatty tissue surrounded by skin, covered by skin. It is the same. In adult female, there will be the glandular tissue, which is in the form, as I told you, of alveoli that secrete to the alveolar ducts. the alveolar, so go to the lactiferous duct that will preserve the milk secreted into a sinus, and finally it opens into the nipple. And as I told you, the ducts open into the nipple, and if we take an incision, we have to take a radial incision from the nipple outside to prevent any cutting of many ducts. If we take the incision here, for example, it will be between two ducts. If it passes by one duct, it's okay, but if we take it vertical or horizontal, it will cut many ducts. This is about the structure of the breast. And about the position of the breast, as we agreed, the breast is present inside superficial fascia, except the deep part of the breast, which is the axillary tail, which goes into the axilla by piercing the base of the axilla, and this is the deep part. When I ask you what are the structures deep to the base of the breast, you will say the muscles and the deep fascia of the muscles. How many muscles we have? Pectoralis major and external oblique, muscle of the abdomen. But when we go laterally, there will be the serratus anterior muscle in the medial wall of the axilla. Now, this finishes with the structure of the breast, and it finishes with in both male and female, there is fibrofatty tissue and the rudimentary glandular tissue in male, and well-developed glandular tissue, as we have seen here, in female. Now, what is the structure superficial to the base of the breast, superficial to the deep fascia of the breast? As we agreed, it is the retromammary space, which is formed of loose areolar tissue. This loose areolar tissue makes the breast easily movable. Now we'll go to another item. What is the blood supply of the breast? If this is the breast, and as we agreed, there is a sternum here, and inside the thorax there is an artery which is called the internal thoracic artery. This is the internal thoracic artery, and from the internal thoracic artery come out the anterior intercostal arteries. And as we agreed, in the axilla, there is the axillary artery. As you know, there is the axillary artery. Now, when I ask, what is the blood supply of the breast? The most medial part of the breast will be supplied by the internal thoracic artery. It takes blood supply from the internal thoracic artery. The middle part of the breast will be supplied by the anterior intercostal arteries, which are branches of the internal mammary artery. The internal thoracic artery supplies the medial side. The middle part is supplied by the anterior intercostal, which come out from the internal thoracic artery. Now, the most lateral part, it will be supplied by the thoracoacromial artery of the axillary and by the lateral thoracic artery of the axillary. So the part near the axilla will be supplied by the axillary. The part near to the thorax will be supplied by the internal thoracic artery. And in the middle, there will be the branches of the internal thoracic artery, which are the intercostal arteries, the anterior intercostal arteries. And the veins correspond to the arteries. They are the same name and they are of the same termination. Now this finishes with the blood supply of the breast. We finished with the base of the breast. The base of the breast rests on retromammary space, which rests on the deep fascia that separates the breast from the three muscles. And we agreed about the structure of the breast, and we agreed about the blood supply of the breast. Now what about the lymph drainage of the breast? If this is the breast, if this is the breast, and this is the part of the breast which is present in the axilla, which is the axillary tail. This is the breast, and this is the axillary tail. We can divide the breast into 4 quadrants and the tail. This lateral half of the breast with the tail are near the axilla. Therefore, they were drained to lymph nodes inside the axilla. The upper lateral quadrant will drain to the apical axillary lymph nodes. The lower lateral will drain to the anterior axillary lymph nodes. And the tail will drain to the posterior axillary nodes. So the lateral part is near the axilla and is drained to the axillary, apical axillary, anterior axillary, and because the tail is deep and is directed backward, therefore it will be drained to the most posterior group of axillary lymph nodes, which is the posterior group. The medial side will drain to lymph nodes inside the body, the trunk. The upper medial will go to the internal thoracic lymph nodes. So the artery is internal thoracic, the vein is internal thoracic, and the lymph nodes of the upper part is the internal thoracic. The vein, the vessels, lymphatic vessels of the lower medial part will go to lymph nodes in the abdominal wall or in the abdominal cavity superficial to the peritoneum. These lymph nodes are inside the rectus sheath or inside the cavity deep to the anterior abdominal wall, between the anterior abdominal wall and the peritoneum. So 3 parts of the axilla to axillary of the breast to axillary lymph nodes, and 2 parts of the breast drain to the trunk lymph nodes. The medial upper to the internal thoracic, the medial lower to lymph nodes in the rectus sheath or inside the cavity between the anterior abdominal wall and the peritoneum. This finishes with the lymphatic drainage of the breast. And if we want to take some applied points of the breast, we'll repeat the same section of the breast. If this is the pectoralis major, and this is the external oblique, and this is the skin of the breast, and this is the nipple, and this is the deep fascia over the muscles. These are the suspensory ligaments of the breast. If there is cancer here, it will stretch and shorten these ligaments. They will become like this. Therefore, they will take the skin to the inside. And if we look to the skin of the breast, we'll find there is dipping of the skin of the breast. Dipping or bitting of the skin of the breast. This bitting or going in to the inside of the skin of the breast, this means that the ligaments have been shortened. So if we have a breast mass, the breast mass may go to the inside to fix the breast to the pectoralis major. And at the same time, this breast mass may shorten the skin and take the skin to the inside, dipping the skin. And as well, this mass will compress the lymphatics of the breast and make the breast edematous. So the breast will be bitting and edematous, looking like the skin of an orange, and this is called bedorange skin, or the skin which looks like the skin of an orange, which is characteristic in breast cancer. So if we have a female and we suspect that there is a mass and this mass is malignant inside the breast, first we'll test the movement of the breast. If it is not easily mobile, this means that the mass has invaded locally the pectoralis major. If we find that there is bitting, this means that the mass have stretched and the ligaments that pull the skin to the deep fascia. So there will be bitting. And if we find that the breast mass looks like the skin of an orange, this means that the lymphatics as well have been compressed and blocked, and the breast becomes edematous. This is what about the applied points. Of course, the lactiferous ducts also will be stretched, and the nipple, because the lactiferous ducts open into the nipple, when they are shortened, we'll find that the nipple will be inverted to the inside instead of being everted. It becomes like this. It becomes inverted. The nipple will go to the inside. So an inverted nipple means that the lactiferous ducts are shortened. Beating of the skin means that the suspensory ligaments have been shortened. If it is edematous, it means that the lymphatics have been blocked. This is what about, and if it is not movable, it means that the malignancy has spread to the inside of the breast. This finishes with the structure, the anatomy of the breast and its applied anatomy. Now we'll go to the development of the breast. The breast develops from the ectoderm between the upper limb and the lower limb. If this is the upper limb, this is lower limb. From the base ectoderm of the front of the body, from the base of the upper limb to the base of the lower limb, this ectoderm will develop and forms a ridge or a line on each side. This ridge or line on each side is called the mammary ridge or the mammary line. This line persists in animals, but in man, in human, what will happen is that the upper part of the line will disappear and the lower part of the line will disappear. and the line will be restricted to the pectoral region only. To the pectoral region only. It is an everted line from, and if we take a section in this line, for example, transverse section, if this is the skin of the trunk, the line of each side will be everted like this. From this ridge appears at the 7th week. The 7th week of intrauterine life. So very early in intrauterine life, the beginning of the breast is in the form of a ridge occupying the whole trunk in animals, but in man, in human, its upper part and lower part disappear. And what will we find will be the part in the pectoral region. If I take a section transverse like this, it will be everted like this. Now what will happen? From this line, of course, here there will be the mesoderm, the underlying mesoderm. From this line, from this ridge, cores will develop to invade the mesoderm. These cores will branch. And they will finally terminate into dilatations. Dilatations like this. So we'll have, if this is the line and this is the everted ridge, and from the everted ridge arise cores, solid cores. These solid cores will give branches, and the branches pass into the mesoderm, the underlying mesoderm, and will terminate into dilatations. What will happen? Overgrowth of this mass to give the cores will make it, instead of being everted like this, it becomes, if this is this ectoderm, it will become inverted to the inside. Inverted to the inside. And this number one, overgrowth and pulling down of the cores to the inside of mesoderm, they will take with them the everted ridge to become inverted like here. Then each duct will be canalized to form the lactiferous duct, and then the small ducts will be canalized and to form the alveolar ducts, and finally will terminate into the acini. This finishes, we have the acini, we have the ducts, and we'll go down. Now what will make, this is actually the site of the nipple, and as we have found, the nipple is inverted here. What will happen is that the mesoderm will grow and will push the inverted ridge to the outside, like this, to become the nipple. And the lactiferous ducts will open into the nipple and will have the mammary gland of the right side and the mammary gland of the left side. This finishes with the development. Of course, the nipple is here. Where is the areola? The areola will begin in the form of a colored mass at the 5th month of intrauterine life. At the 5th month of intrauterine life, the areola begins, and this finishes with the development of the breast. Now, what are the congenital anomalies of the breast? We may have along the mammary line more than one breast if it doesn't disappear. If it doesn't disappear, there will be many mammary glands. This will be called many subjects with many polymastia. Polymastia means that there are many mammary glands. Or a breast will develop in this site, for example, but will have nipples, more nipples along this mammary line. These nipples, many nipples, will be called polythelia. So the first anomaly will be either there are many mammary glands, polymastia, or there is one mammary gland and more than one nipple in each side. This is called polythelia. These are the two types where there is increase in number of nipples or increase in number of breasts due to persistence of the mammary line. Now, are there other anomalies? Yes, there are other anomalies. The breast may be less than normal, will be smaller than normal. This will be called micromastia, micro. Or it be larger than normal, it will be macromastia. If the female is fatty, for example, or if the glandular tissue is developed, and if there are some hormonal disturbances. If the breast is larger than normal in a male, we call it gynecomastia, gynecomastia. And this is usually due to hormonal disturbances, or it may be due to obesity. So, according to the anomalies, we have polymastia or polythelia when the nipples are more than one on each side, or we have macromastia or micromastia. Are there any other anomalies? Yes, as we agreed, the mesoderm will push the ectoderm to the outside and the nipple becomes everted. If the mesoderm does not develop and push the nipple to the inside, the female will be born with an inverted nipple. The inverted nipple will be a disability to the baby. He will not be able to suck the milk from this inverted nipple. Also, it will be a subject of problem to the female because the inverted nipple through which the sweat or the infections may go to the inside, it will be a source of infection to this female. So the anomalies again, polycyria, polymastia, macromastia, micromastia, and gynecomastia in male when the mass is more than normal. What happened is in this lecture, we have taken the base of the breast, the 3 muscles related to the base of the breast, and the deep fascia covering them. The space between the breast and this muscle is called retromammary space. It helps movement. If there are no movement, easy movements, this means that there are some masses invading the pectoralis major and the other muscles. And the structure of the breast is formed of lobes separated by suspensory ligaments, and the lactiferous ducts are present inside the fat of each lobe, directed to the nipple, radiating to the nipple, and we have to take the incision radial. And as regarding the embryology, it develops from ectoderm invading the mesoderm, and the ectoderm will form cords, and the cords will end in dilatation, which are the acini. And finally, the nipple, instead of being inverted, it will be everted. If it remains, this means that there is inverted nipple. This is a bad congenital anomaly. Thank you very much.